back, following which she developed lower abdominal pain, which was localized to the lower abdomen for 4 months and non-radiating, intermittent, dull aching in nature, no particular aggravating factor, and relieved by medications. And also complaints of lower abdomen distension for past 2 months, which was insidious in onset, progressive in nature to attain the present size. No history of nausea, vomiting, altered bowel, no history of melena, bleeding PR, bleeding for vagina, vaginal discharge, no history of fever, trauma, loss of weight, loss of appetite, no history of cough, breathlessness, bone pain. Patient did not have any comorbid illness or previous history of surgeries, and she consumes a mixed diet with normal bowel and bladder habit with a normal sleep pattern. She attained menarche at 13 years of age. She had a regular 3 by 30 day cycle, and she was married at the age of 21. She is para to live to. First childbirth was at 22 years of age. She was breastfed for more than 1 year and attained menopause at 47 years. And there is no history of OCP or hormone replacement therapy usage. And no history of malignancy running in the family like breast, ovarian, colorectal, pancreatic, or any other malignancy in both male and female.
Okay, just stop for a little while. Uh, uh, can you just go back to your history? First of all, can you summarize your history? Just summarize your history in 1 or 2 lines.
Yes, ma'am. My patient is a 65 years postmenopausal lady presented with lower abdominal pain for 4 months with complaints of lower abdominal distension for 2 months with no other significant previous or family history.
Okay, so can you just go back to your slides? We'll just discuss the history right now itself so that we can get this out of the way. Okay, the second slide, please. The next slide. Yeah. So she had lower abdominal pain, which was non-radiating, intermittent. Many times these ladies describe the pain as a dragging sensation as well, rather than intermittent. The only comment was that you can just say the abdominal distension was insidious in onset and progressive in nature. It is difficult to determine the size of distension clinically or on history. You can just write it was progressive in nature. That's it. Because you don't measure the distension in terms of size. You can measure the lump or mass in terms of size, but not distension per se. That's the only comment. Yeah, next slide, please. Yeah, so now this negative history, just go one by one. I'm sorry, I don't know your name.
Ma'am, Sunita.
Yeah, Dr. Sunita. So just discuss why you have taken all these negative histories one by one.
Okay. For nausea, vomiting, first to rule out any GI pathology, ma'am, upper GI pathology. And for altered bladder habit, first is to rule out any compressive symptoms from pelvic mass or per se any bladder mass for hematuria, dysuria, and urgency frequency, ma'am.
Basically, so when you're taking a negative history, you're trying to rule out the causes of this abdominal distension and the pain. Number one, when we take negative history, we take negative history to rule out the causes, 1, 2, 3, 4, and we also take negative history to see what is the extent of the disease. So, like you rightly said, that you are taking bladder habits because if the mass is there, if it is increasing in size, what is the extent it is involving the bladder or not? Yeah, and the bowel habits. Yes, please go ahead.
Bowel habits, compressive symptoms or involvement of rectum. It will show as bleeding PR and melena. And bleeding PV and vaginal discharge, whether it is associated with any endometrial malignancy or some ovarian mass itself causes bleeding PV.
Which ovarian mass causes bleeding PV in this kind of a setup?
Granulosa cell tumor.
Correct. And which can cause a clear watery vaginal discharge?
Primary fallopian tube malignancy.
Yeah, very good. Yes. Okay. Yes.
And then fever, trauma, loss of weight, loss of appetite for fever and constitutional symptom to rule out any tuberculous abdomen.
Okay. So why trauma then?
Fever, trauma, for any trauma to the abdomen causing hematoma or something, ma'am. Abdominal,
Very less
less
likely.
likely.
He
Yes, ma'am.
would give, see, anybody who has a history of trauma would give you a history. So
Yes,
don't give extra negative history, so that, if the more negative history you give or the more extra you speak, the more you give a chance to the examiner to catch you. So you
okay,
can
okay,
remove
ma'am.
this trauma. Okay. If a
Okay,
patient has trauma, she normally, she tells it. She's
ma'am.
forthright with it that, she had a trauma, she fell down, then she started having pain abdomen. If the
Okay, ma'am.
patient has not told you, this is okay. So constitutional symptoms, yes. Why do you want to ask for constitutional symptoms?
Ma'am, tuberculosis, ma'am.
Correct. So in Indian setup, pelvic tuberculosis or abdominopelvic cox both are differentials in C ovary, and that is why we want to rule out. And similarly goes for cough,
Cough,
breathlessness.
breathlessness for tuberculosis and for second, I mean, metastasis, ma'am. Lung.
Again, bone pain. So, per se, the incidence of bony metastasis in C ovary is very, very rare. Very, very rare. Okay. So,
Okay, ma'am.
leave it out. I would suggest just leave it out, because this
Okay,
is
ma'am.
a general history which you take for all cancers. I agree, but you need to tailor your history according to what kind of a case you're taking. Okay. So, bone pain, it's not required, because per se, the history for ovarian, the chances of bony mets is very, very less. Okay. So, yeah,
Okay.
please go ahead. Yeah. Yeah, no history of comorbid consumes menstrual history. Yeah. So, why is menstrual history important?
Ma'am, menstrual history, because we have to see the first age group of the patient, ma'am. In different age group, different ovarian neoplasm is common.
Yeah,
And
we know she is 65,
65.
but why have you have taken a good menstrual history? Why have you gone along, why have you taken such a detailed menstrual history? Why is it important in this case?
Ma'am, I mean, early menarche, that is the woman who is having many cycles have the chances of increased malignancy due to that incessant ovulation, causing
Correct.
repeated trauma to the ovary,
Yeah.
causing dysplasia and ovarian malignancy is one. And we have to see the menopausal age and use of OCP, the same thing, ma'am. For 5 years, if the lady is using, then it is protective.
Right. So, in this menstrual history, you have taken this history because there are many risk factors and protective factors. So, the risk factors, so early menarche, late menopause, okay, not being able to conceive, not having children, not breastfeeding. These are all risk factors for ovarian cancer. The use of HRT is controversial, but yes, it has been in many studies, it has been associated with a slight increased risk of ovarian CA. And OCPs and breastfeeding, they help in reducing the risk of ovarian cancer. That is why all this detailed menstrual history is important. Okay, so that is, you've taken the correct history. All this should be taken. So yeah, so this is the reason why we focus on menstrual history. Okay, next slide, please. Yeah, why have you taken this history?
Ma'am, to rule out familial malignancy, ma'am, in
Which
ovarian,
syndromes do you want to rule out in these cases?
hereditary breast ovarian cancer, Lynch syndrome, Peutz-Jeghers syndrome,
Yeah.
Cowden syndrome.
Yeah, so Peutz-Jeghers and Cowden are relatively rare, but yeah, more importantly, the hereditary breast ovarian. So you've
And
asked for breast, ovarian, pancreatic, and correctly you've asked for colorectal also. In case a patient does not tell you everything, because many times the relatives don't know whether the relatives had. So you can just say no history of any abdominal malignancies as far as the relative knows about it, and you have to mention the one line in this in either the first or the second degree relatives from mother's or father's side. Okay, because the examiner may ask you till what level did you take the family history. So you have to make sure paternal history is very important, because many times BRCA is inherited through the paternal side. So you
okay.
have to take you have to mention that none of these cancers are present. There's no history of these cancers in either the first or the second degree relatives, both on the maternal as well as the paternal side. So you need to add this statement. Okay. ठीक है, okay. Yeah, go ahead with the examination.
Okay. On examination, after obtaining consent, patient is conscious, cooperative, oriented, moderately built and nourished with ECOG score of 1. Vitals BP 120/70, pulse 72, no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Examination of skull, spine, bone normal, and examination of bilateral breast and axilla normal. Systemic examination, cardiovascular system, respiratory system, and central nervous system examination is normal. Now moving on to per abdomen examination. Inspection, patient in supine position, umbilicus in central and inverted. Respective quadrants move symmetrically with respiration. There was an obvious lower abdominal fullness noted involving the pelvic and left iliac fossa up to 4 centimeter below the umbilicus. There was no scar, sinus, pulsation, peristalsis, and dilated veins, no renal angle fullness. Hernial orifices free, no supraclavicular fullness, and external genitalia appears normal. On palpation, there was no warmth, a firm, non-tender mass of size 10 into 10 centimeters, palpated in the lower abdomen, extending 2 centimeter medial to the left iliac fossa, up to just crossing the midline, and 4 centimeter below the umbilicus. Superior right and left border felt, and inferior border could not be made out. With smooth surface and restricted mobility, no other organomegaly, bilateral supraclavicular region examination normal, no inguinal lymphadenopathy. Percussion, there was dullness over the mass and resonant elsewhere. Auscultation, normal bowel sounds. Pervaginal examination, external genitalia looks healthy. Cervix and vagina was normal, and there was a hard POD deposit of size 2 into 2 centimeters palpated. On bimanual palpation, mass was palpable in the left fornix, which was firm in consistency with restricted mobility.
Okay, yeah, just you can leave this. Just go back to your examination, the slides again, examination slides. Yeah. Start from your first slide of examination. Yeah, okay. No pallor, icterus. Cyanosis is not something you would expect in these kind of patients. You can even avoid it. We say it because we have learned it as MBBS students. You need to realize you'd be taking a DNB exam for a super specialty. So you needn't be this, you needn't give this history, which is, expected out of an MBBS student. We don't really expect cyanosis and clubbing in patients of CA ovary. Now you've said generalized lymphadenopathy. So what all lymph nodes should you inspect, palpate, or whatever in a case of CA ovary?
Supraclavicular node and axillary and inguinal nodes.
Correct. Very good. Yes. Now go on to your second slide. Normal systemic examination is normal. Right. All right. Okay. Next slide, please. Yeah, so here you have mentioned everything correctly. My only comment was the last line, no supraclavicular fullness. So I think for lymphadenopathy, you've already, done that in the general examination. So when you say general examination, you can say no lymphadenopathy, including supraclavicular, bilateral axillary, and bilateral inguinal lymph nodes. Because when you come to inspection palpation, we are mostly concerned about the abdomen because we've ruled out the systemic, we've done the general examination. So lymphadenopathy, mention it in the first setting, when you mention your general examination. When you're saying lymphadenopathy, say no lymphadenopathy, including the supraclavicular foci, bilateral axillary, and bilateral inguinal region. So when you come to per abdomen inspection, palpation, percussion, that should refer to the abdomen only. So supraclavicular fullness, I think you don't mention this here, mention it in your general examination. Similarly, external genitalia healthy. So after you've done your per abdomen examination, before you move on to a PSPVR examination, there you say external genitalia is healthy. When you're doing when you're talking about abdomen, let's just talk about abdomen. Don't move to supraclavicular fossa and then to external genitalia. Okay, so this is just abdomen. Fine. Next slide, please. Yeah, I could not understand this. A firm non-tender mass of size 10 into 10 centimeter palpated in lower abdomen, extending 2 centimeter
Anterior,
Medial to left iliac fossa up
anterior
to
superior spine, it
up
is.
to just crossing the midline and 4 centimeter below the umbilicus. So you need to write this in a simpler way because your examiner is going to get confused. I mean, I am confused. You can just write a 10 into 10 centimeter abdominopelvic mass is palpated,
Mm,
reaching up to 4 centimeter below the umbilicus. Okay. You
mm,
needn't go into detective details like, it is going 2 centimeter medial into left iliac fossa crossing the midline. Once you say it's an abdominopelvic mass, we assume it's an abdominopelvic mass because you're giving a super specialty exam. Okay? So just say a 10 into 10 centimeter abdominopelvic mass is felt in the lower abdomen, reaching up to 4 centimeter below the umbilicus. How do you know it's an abdominopelvic mass? Like you have
okay.
rightly mentioned in the next slide, that the inferior border is not
It's
made out. That is why we know it is arising from the pelvis, not the abdomen, which is going. So if there is a big mass which is going into the pelvis, how do you sort of clinically distinguish whether it's arising from the pelvis? Most of the times, if it's arising from the pelvis, you cannot reach the lower border.
lower body.
Whereas if it's in a big abdominal pelvic mass which is moving into this thing, if it is mobile, you can reach the lower border. So this is okay. Again, bilateral supraclavicular fossa, inguinal nodes, please don't mention it here. This is just abdomen. Okay. So here you can say on palpation, a 10 into 10 centimeter, what have you written? You have to mention firm or this thing. A 10 into 10 centimeter firm abdominopelvic mass is felt in the lower abdomen, reaching up to 4 centimeter below the umbilicus. The surface is smooth, mobility is restricted. No other organomegaly. Okay, that's it. And hernial sites are free. Okay. Now
It's okay.
let's go to the next slide. Dullness, this is okay. Yeah. Cervix and vagina normal, hard deposit. You have not mentioned anything about the uterus. How was the uterus? And it should not just be PVR, it should be PSVR. Okay, at least in the exams you have to
Yes,
mention that.
okay. Okay,
Okay.
ma'am.
So after abdomen, local examination, external genitalia is healthy. Then you go to the PSPVR examination. So cervix is vagina is normal, cervix is healthy. What was you have to mention the uterus. At
Yes.
least, even if you cannot measure the size of the uterus, that is fine. But you need to measure the uterus. You need to mention the uterus. The reason for that is, in case there is a mobile mass, okay, so the uterus will be felt separate from the mass because after examination, we will be talking about the DDs, okay. So many times, so how do you know it's an ovarian mass? That would be the question which would be asked to you. So if you have felt uterus separate from the mass, you are reasonably sure we are dealing with an adnexal mass. Many times you cannot feel the uterus separate from the mass if it is big, if it is huge. Okay. Like here, it's a 10 by 10 centimeter mass. If it is adherent, or it is extending into the pouch of Douglas, many times you will not be able to feel the uterus separate. But you can mention that uterus not felt separate from the mass and the size could not be assessed. That is completely acceptable. In a big mass, you may not be able to feel the uterus separately. But if you are able to feel the uterus separately, that definitely clinches a diagnosis which goes more in favor of an ovarian mass. How do you know that it is, how do you feel whether the mass is separate from the uterus or not on clinical examination?
Ma'am, one with that on moving with bimanual palpation on moving the cervix, if you able to see that the direct movement with the mass, then it is an uterine mass. If
Correct. Very good.
it's
Yes.
not,
So that is called cervical motion is basically if the cervical motion is being transmitted to the mass, it is more likely to arise from the uterus. Correct. You're absolutely right. So you just need to mention this uterus. Okay.
okay.
Fine. Bimanual mass felt in the left fornix, firm in consistency with restricted mobility. And just mention about the rectal mucosa as well, whether the rectal mucosa was normal or not, because you're
Okay.
doing a complete examination. Okay. So vagina is healthy, cervix is normal. Uterus could not be felt separate from the mass. The same mass was felt. I'm assuming that 10 centimeter mass also you could feel from below. So you should always mention the same mass was
Mm,
felt on pelvic examination. In
okay.
addition, a hard POD deposit of about 2 into 2 centimeters was felt, which was firm in consistency with restricted mobility. The rectal mucosa was free. So that completes your pelvic examination. Okay. So be a little concise. You don't have to elaborate everything like we do in MBBS exams because this is a super specialty exam. Otherwise, you'll be spending the whole time only on history and examination. You'll not come to the management. Okay. So be a little concise with your words. Okay. Okay. Next slide, please. Okay. Now I think your examination is done.
Yes, ma'am.
Okay. Can you summarize the case in 2, 3 lines?
Yes, ma'am. My patient is a 65 years postmenopausal lady presented with abdominal pain for 4 months with abdominal distension for 2 months. On examination, there is a 10 by 10 centimeter abdominopelvic mass noted with restricted mobility with hard POD deposit of size 2 into 2 centimeter noted.
Okay. So on the basis of your history and examination, what are your differential diagnosis? What is your diagnosis and what are your differentials?
Ma'am, my first differential diagnosis would be an ovarian mass of malignant etiology, ma'am.
Okay.
First,
So what are the factors? Okay, first mention your DDs, then we'll say what are the clinching factors or not. Okay. One is your ovarian mass, likely malignant. Any other differential?
um, ma'am, maybe uterine mass also, ma'am.
Okay. What kind of a uterine mass can present with a POD deposit?
Ma'am, sarcoma, ma'am, uterine sarcoma, because this much big in size.
Okay. All right. Anything more common than a uterine sarcoma?
Mm.
It doesn't necessarily have to be uterine. One differential you have said is an ovarian malignancy. Okay. What is the second? The second differential you've said is uterine sarcoma. Now, uterine sarcomas are not very common, so don't mention them so higher up. There is another possibility. Can you think of another possibility? A non-malignant possibility?
Benign and next symptom as well.
Yeah, which benign adnexal cell mass?
Granulosa, I mean, say 6 cord tumors, ma'am.
नहीं बचे.
Next slide.
Okay, so
They,
an endometriotic, so if endometriotic masses can present as ovarian masses, big ovarian masses, and they can present with POD deposits. Okay, so POD
So
deposits, yes, someone has already mentioned this, correct. So, chat box. So your friends are prompting you on your chat box. You can check your chat boxes as well. So endometriosis, yes, very good. The person who's mentioned that. So yeah, we can have adnexal masses with endometriosis with raised PA125 later on. We'll, of course, discuss the investigations, and these can present with POD deposits. Routinely, when we examine the patient for endometriosis, any patients with endometriosis, we always do a PVR examination to assess POD nodules, to assess thickening of the uterosacral ligaments, because that helps us in clinically grading the endometriosis to decide whether the patient actually requires what kind of treatment. Okay. So, all right. Now, so first differential is so what are why do you think it's a malignant ovarian mass? Is there something in your history as well as in your examination which sort of favors this diagnosis?
ma'am, elderly, more than 60 years, ma'am, female lady,
Postmenopausal lady.
postmenopausal lady, with
Yeah,
shorter duration of history, with no constitutional symptoms.
yeah.
Uh, and on examination, there is an mass which was clinically abdominopelvic mass with an POD deposit.
Correct. Okay. All right. So it is basically, yes, she's in the postmenopausal age group. She's 65. This is like the commonest age. 63 to 65 is the commonest age for these kind of tumors. Plus the fact that there is on examination, there is a mass with a POD deposit. Your first differential will be to rule out a malignant ovarian mass. Second can be endometriosis. Uterine sarcomas would come lower down. In case there was no mass, this is just a possibility. In case there was no mass, there was only ascites, and you could feel on pelvic examination these nodules in the pouch of Douglas, and you could feel ascites. Uh, could you keep a third differential as well in such cases? If in this case there was no mass, there was only ascites, and there was deposit in the pouch of Douglas, could you have thought of any other possibility?
Ma'am, The Meeks,
Meeks to there's no okay, fine. Meeks is there in case there is a mass. Definitely, you can think of Meeks. I'm talking of only ascites where you cannot definitely feel a mass, but you can feel these nodules in pouch of Douglas. Tuberculosis, abdominopelvic cox. Okay, they can present with ascites. They can present with nodules in pouch of Douglas. You can feel even thickened adnexa on pelvic examination. That's a very common differential you have to keep. And many times abdominopelvic COX may not present with constitutional symptoms. Constitutional symptoms are not that common in abdominopelvic COX or even pelvic COX for that matter. Okay, so you still have to keep the differential in India. Okay, so you have, so now what investigations would you do in order to come to your diagnosis and further management? First
ma'am.
answer, then you can go ahead with your slides.
Okay, ma'am.
Mm.
Basic blood investigation with tumor markers and imaging with CCT, abdomen and pelvis with thorax, ma'am.
Okay, so what blood investigations would you do?
Ma'am, basic blood investigation with CPC, liver function tests, urea creatinine, and viral markers with the tumor markers CA-125, CEA, and CA-19.9.
So why do you want to know CBC, KFT, LFT? Okay, one is that you may be preparing her for surgery. But other than that, can it tell you something about the disease or about the patient's status?
Ma'am, hemoglobin to see for nutritional anemia and
Correct.
ID, and
What else?
albumin for nutritional status, and
Right.
creatinine for further investigation we need, ma'am, for contrast studies we need.
For contrast and also for pressure symptoms. So
Yes,
many times, you can find masses which are compressing on the ureters, causing upstream hydronephrosis. So that is why renal functions are important. Hemoglobin is important, albumin is important. Because even though this is an early case, sometimes in most of the cases you will deal with advanced cases, and that will help you in deciding what type of a treatment you want. Do you want to go for surgery first, or do you want to go for chemo first? So, okay, tumor markers, CA-125, CA, and CA 19.9. Okay, so what is the sensitivity of CA 125?
in early ovarian cancer, it is 50%, ma'am. In local advanced, it is 75 to 80%.
Okay, so is it a very specific marker?
It is a sensitive marker, ma'am.
Okay, so why is it not a very specific marker?
Because it is also elevated in other conditions like endometriosis, adenomyosis, and peritoneal irritation, tuberculosis.
Yeah. What
Increase.
you can, yeah, so you can divide these causes into gynecological and non-gynecological. So CA-125 is a non-specific marker because it can rise in gynecological conditions, benign, sometimes benign masses, endometriosis, pelvic inflammatory disease, uterine fibroids. Okay, it can vary with the menstrual cycle as well. Okay, and adenomyosis, and non-gynecological causes can be any causes which is causing peritoneal irritation. Okay, abdominal pelvic cox, um, this pleurisy, pericarditis, cirrhosis, okay, diverticulitis, anything which causes peritoneal irritation can cause rise of CA 125. Okay, why do you want to do CA and CA 19.9? Why isn't CA 125 enough?
Ma'am, CA for CA is to CA 125 ratio. It will be useful in case of doubt from which origin, ma'am. More than 25 indicates it's an ovarian origin. Less than 25, it is an GI origin, ma'am.
Yeah, so basically what you should say is that in an ovarian mass, in about 15% cases, we can find metastatic masses which may be arising from upper GI, from pancreatobiliary tract, from your colon, from stomach, from breast. So it can be a metastatic disease in up to 10 to 15% cases. So in
Okay.
order to rule out metastatic disease, that is why we routinely at least advise CA, and many centers, including us, including Tata, are following CA 19.9 as well. And like you rightly said, if a CA 125 by CA ratio is more than 25, it is more likely to indicate an ovarian etiology. And if it is less than 25, we have to rule out GI causes as well. Okay. Now, imaging. So what imaging would you do? You had said something. Can you just repeat that?
CT, abdomen and pelvis, ma'am. With
Thorax as well, right?
thorax, CT thorax,
Yeah, correct. So what would you want to see in a CT scan? What all things would you want to see in a CT scan?
ma'am.
Yeah, okay, you can show the CT scan and then tell us what all features do you see in a CT scan to actually decide your management.
Okay, ma'am.
Hmm.
First, there is in lung, there is no obvious pleural effusion, ma'am.
Hmm.
Then first we'll see for any liver deposits.
Yeah.
Uh, no obvious ascites.
Hmm.
Now we have to see the retroperitoneum nodes, ma'am. And
Yeah.
then any involvement of bowel surface or peritoneum involvement.
Hmm.
This is the mass, ma'am.
Okay.
Uh, Huge mass with thickened septa with solid components. Thickening of the septa with solid components is there, ma'am. It is probably from the left ovarian origin. And here we can see the thinned out uterus, ma'am, behind.
Okay.
And I think this may be the right ovary, ma'am.
No, just go down. So,
Ovary or
yeah,
left?
come at this level. Yeah, yeah, yeah. No, no, no. Huh, yeah, okay. So, at the level where you, this is, of course, this is a CT, but this applies for MRIs as well. Wherever you see these femoral heads, that is the level of vagina and lower cervix. Okay.
Okay.
So, this is the starting of vagina. Okay. Now you go up. Yeah, go up, go up, go up.
Rectum is not.
Correct. Yeah, so that is basically the uterus, the cervix is deviated to one side. It could be the other ovary which is stuck. Yes, you are right. Okay, fine. All right. So in a CT, thorax, abdomen, and pelvis, you are basically trying to rule out any metastatic disease and what all disease is present. You have to assess the peritoneal disease. The peritoneal disease includes any peritoneal thickening, peritoneal deposits, omental disease, any serosal deposits. You also have to see any deposits on the surface of the liver, on the spleen, okay, and mesentery. Mesentery is very important, especially in advanced cases, because that would be the clinching, one of those clinching factors which will take you either towards chemo first or towards surgery first. And like you rightly said, we have to assess the retroperitoneal nodes and the pelvic lymph nodes. Okay, so why not a PET CT or why not an MRI? If somebody was to argue, why did you choose a CT? Why not a PET CT or why not an MRI? So, what would your answer be?
MRI is used to characterize the ovarian mass lesion in case of younger individual whom we have to characterize between benign and malignant. It is useful, ma'am. And PET, as such, it is useful only in, mostly in recurrent cases because it has high false positivity rate.
Okay,
So,
correct. So, see, MRI is more, like you said, MRI is more useful to characterize the lesion. In a case of a premenopausal lady, where it would have changed our management, where we are trying to distinguish between, say, an endometriotic, a complex mass, like an endometriotic mass versus a malignancy, there MRI is important. In an old lady, so now the disadvantage of MRI is that A, it is expensive, number one. B, it is not available everywhere. Okay. Third, this lady is already postmenopausal with a 10 centimeter mass. Okay. Here, I'm assuming you have the facility for frozen section at your center.
yes,
So,
ma'am.
in most cases, you have. Okay. So, where patients, there are some centers in India where, they don't have the facility for frozen. There, you might think of doing a MRI as well. Okay. We are not talking of those places. We are assuming when we are taking our exam that we have facility for a frozen section. So here, it's a big mass. We will be doing a frozen section for this mass, so we need not, actually do an MRI in this case. And MRI is more expensive. It has patients may have claustrophobia, and it may not be available everywhere. And most importantly, in this case, it will not change your plan. Okay, it is a 65-year-old lady. She has a suspicious mass. You see this on CT. In any case, you need to explore her. Okay, so it will not make a difference here, but it does make a difference in young patients. But if you had let us say you had all the facilities, you had all the, the paraphernalia, Would an MRI still help in this patient? Not in this patient, in a case of CA ovary? Where can it help? One is young patients. Where else? Okay. So, peritoneal disease, okay, can be basically picked up very well with a contrast enhanced MRI with diffusion weighted imaging. In fact, there are many centers, especially who are into peritoneal surface oncology, where they are routinely doing, especially in Europe, where they are doing contrast enhanced MRI with DWI. So that is basically to pick up small peritoneal disease. They can pick up peritoneal disease, which is uh, up to 5 millimeter in size. So that also helps us in clinically going ahead either with chemo or with this or with surgery first in advanced cancers. Okay. So, MRI is useful in young patients, in distinguishing between, in a complex mass, in distinguishing malignant masses from potentially benign masses, number one. Number two, even if it's a malignant mass, in a young patient where you are considering fertility sparing surgery, there you have to do an MRI because you have to assess the other ovary. Okay. So, the other ovary cannot be assessed with a CT scan in a young patient with an early disease. Okay. So, okay, let me first ask this question. Although I think we should ask this later. We'll discuss this later, doesn't matter. Where we are doing fertility sparing surgery in a young patient, we need to assess the other ovary. Okay, the other ovary can only be assessed through an MRI, not through a CT. So you have to do, wherever you're contemplating fertility sparing surgery, you must do an MRI, not a CT. And it should always be a contrast enhanced MRI. Okay, now PET CT, like you rightly said, it has many false positives. Number one, A, it is more expensive. B, it may not be available everywhere. Third, it does not add to your information. A good contrast enhanced CT will give you probably more information than a PET CT many times if it is read by an experienced radiologist. And many times the CT slices in PET CT are thick. Okay, if you do a thin slice CT, that may give you more information if read by an experienced radiologist than a PET CT. PET CT is more important in gynae oncology. The absolute indications of doing PET CT is recurrent CA ovary, where you are contemplating secondary cytoreduction, and in leiomyosarcomas. Okay? Leiomyosarcomas, we must do a PET CT. Now, there is some evidence of PET CT in GTN also, but these two indications you should remember. Okay, these are the absolute indications of PET CT. Otherwise, it does not add much to your CT. Okay. So, briefly, can you tell me what are the risk factors for ovarian cancer? You have already mentioned a few, but what are the risk factors and what are the protective factors?
Okay. Elderly female, early menarche, late menopause, with nulliparity, infertility, smoking. Um,
Smoking is a protective factor. It decreases the ovarian. Smoking is a protective factor. This thing. Uh, it's unusual, but yes, smoking is protective actually. Yeah.
okay.
Early menarche, late menopause, infertility, not breastfeeding. Yeah. What else?
Nulliparity.
Yeah.
Um, and protective factor is multiparous breastfeeding, use of OCT.
You missed some risk factors. Not necessarily in this case. What are the other risk factors for ovarian cancer? Untreated endometriosis, PID. Okay. Family history. You had talked of family history. Okay. So, when do we normally, so what are the two important genes? What are the important genes in hereditary breast ovarian cancer syndrome?
BRCA1, BRCA2, RAD51CD, P53.
Yeah, so you have some minor genes, okay? And in fact, there was an Indian study where they said that you should not be just, when you are assessing, when you're doing a genetic screening. So all patients of high-grade serous ovarian cancers must have a genetic screening, okay? So when you're doing a genetic screening, it should not just be BRCA1, BRCA2. 16% of Indian population was actually found to be positive for minor genes, okay? So it should be always be a comprehensive gene panel, okay? Now we talked about endometriosis. Forget about this case for a while. What are the types of ovarian cancers which are linked to long-standing endometriosis?
Endometrioid type of ovarian cancer.
What else?
And clear,
Clear cell and
and
low-grade serous.
Very good. Yes. So it is endometrioid, clear cell, low-grade serous, and rarely even carcinosarcomas of ovary can be associated with endometriosis. Okay. So, all right. Now, okay, now you come to, okay, you've done the CT. Now come to the management part. Yeah. How will you manage this patient?
ma'am, after getting fitness for surgery, I will proceed fitness and consent. Then I will proceed for staging laparotomy, ma'am.
Okay. Yeah. So, how will you do a staging laparotomy? Can you describe the steps of staging laparotomy one by one?
After general anesthesia, I'll put a midline incision from xiphisternum to pubic symphysis. Then I'll collect fluid for cytology. If there is no ascites, then washings for cytology from all the quadrants, ma'am, from pelvis, paracolic gutter, and bilateral diaphragmatic area. Then I will assess the abdomen, ma'am, from starting from the right iliac fossa ileocecal junction, then right paracolic gutter, then bilateral subdiaphragmatic area, then stomach, splenic area, under surface of liver, porta, lesser sac. Then I'll complete the left paracolic gutter, rectum, and then to pelvis, pelvic area. Then first I will proceed with, since it is a left ovarian mass, I will do left ovarian mass dissection and send for frozen. And then I complete my staging with TH with BSO. With ma'am, in this case, this pelvic deposit was there. Um, so pelvic peritonectomy with infracolic omentectomy and bilateral pelvic node dissection and infrarenal paraaortic node dissection with biopsies in the upper quadrant, ma'am. There is no any disease.
Okay, all right. So, yeah, you've described it very well. So, you don't necessarily, okay, just two things. You don't necessarily have to go to xiphisternum straight away, okay, because this is an early case, okay. We are not doing a total parietal peritonectomy that you have to extend. Rather than giving such a big incision, what we normally do is we start from below and then go upwards. We assess how much, the incision we need to take, because there is a lot of peritoneal disease, which the peritoneum can also be inspected and palpated. You needn't go right up to the xiphisternum in an early case, number one. Number two, when there is a big mass, many times, okay, so you may, in your exam, you may have a 10, 12, 15 centimeter mass. So many times, when the mass is in situ, it may not be possible to palpate all the areas. So what we normally do say what you do normally, okay. We normally first remove the mass so that there is space inside the abdomen. Okay, so once there is a big mass, like a 10 or 15 centimeter mass, if you can assess, well and good. But many times when the mass is big, we remove the mass first and then we start palpating. So you talked rightly about going, taking, we should take 50 to 100 ml of fluid from each quadrant. Okay. So the quadrant is, you take it from the pelvis, from the pouch of Douglas, from the right paracolic gutter, from the left paracolic gutter, under surfaces of the diaphragm. How do you take, if your incision is small, how can you take cytology from the undersurface of the diaphragm?
Ma'am, with that Riles tube or any tube we can collect.
Correct. Very good. So Riles tube, infant feeding catheter, red rubber catheter, you just take an asepto syringe, push saline in it, and then take it out, or a 2 syringe and just take it out. Okay. Then what you forgot to mention probably, or maybe I did not hear, is you need to inspect the bowel. Okay. So you need to inspect the bowel, small bowel and the large bowel, right from duodenum up to terminal ileum, and then all the large bowel, inspecting serially both the serosa and the mesentery on both sides of the bowel. So you need to assess that as well. Okay. And under surfaces of the diaphragm. Correct. So you do take biopsies. So here in this case, there was a the pouch of Douglas deposit. So clinically, at least a stage 2 disease. So you decided to go ahead with a complete pelvic peritonectomy, including bladder?
Yes, ma'am.
Okay. Chalo, okay, that's a controversial question. Let's leave that. Okay, all right. So you excised this thing and then you took random biopsies. Where do you take the random biopsies, random peritoneal biopsies from?
From the anterolateral right and red paracolic cutter area, ma'am,
Hmm.
and diaphragmatic surfaces.
Okay, correct. So now, let us say there was only this mass, there was no pouch of Douglas deposit. You were not doing a routine pelvic peritonectomy. Okay, where all would you take the biopsies from?
Ma'am, then
How do you
from
label these ideally? I mean, theoretically. I know practically most of us may not be doing everything, but theoretically for your exams, you have to take biopsy from each pelvis. So right pelvis, left pelvis, from the bladder peritoneum, from the pouch of Douglas peritoneum, right paracolic gutter, left paracolic gutter. Under surfaces of the diaphragm, you can use a tongue depressor to just scrape it and send it for cytology. Okay. So this is the theoretical, although we may not be doing all parts of it, but theoretically, this is how you should be doing it. Okay. All right. So you did this. Okay. Now the frozen section in this lady came back as high grade serous and you did a THBSO, infracolic omentectomy and lymph node dissection. Okay. So why do you want to do, in this case, CT was showing no lymphadenopathy. Why do we do a systematic pelvic and paraortic lymph node dissection in a case of early CA ovary?
Ma'am, in early ovarian cancer, to stage the disease, we have to do because in 20 to 25% of the cases, it will upstage, ma'am, pelvic, the lymph node dissection. So for
Okay.
staging the disease, we have to do in early ovarian cancer.
Correct. So now is doing pelvic lymph node dissection enough? Why do we have to do a paraortic as well?
Ma'am, parietic also, it's important, ma'am, till
Why?
the infrarenal level, because
So because the infundibulopelvic ligaments, they basically travel right up to the IVC. Right side, the right ovarian vein drains into the IVC. The left side, it drains into the left renal vein. So the lymphatics along these, they go into the paraortic region. Secondly, unlike say CA cervix or CA endometrium, so in CA cervix and CA endometrium, if you don't have a positive pelvic lymph node, the chances of finding an isolated paraortic positive
it's
lymph
less.
node is very less. It is just 1%. On the other hand, in a case of CA ovary, the chances of finding isolated paraortic lymph node mets is up to 16 to 20%. Okay, up to 20%. So in up to 20% cases, you can find isolated positivity only in the paraortic lymph nodes without a pelvic lymph node involvement. Okay, so that is why you should do a complete lymph node dissection. Reason being, it upstages the disease. Okay, in many it can upstage the disease in 20 to 25% cases. That will help us in prognosticating the disease. Number two, deciding on any change in the adjuvant treatment. Okay, so now is there any what do you do lymph node dissections in all cases, in all types of ovarian cancers?
No, no, ma'am, all type. This is for germ cell tumor. You're asking in that way, ma'am.
Yeah, so in which okay, what I'm trying to say is in which type of ovarian cancers can you avoid systematic lymph node dissection in early cases?
Ma'am, in early cases, germ cell tumors, we can avoid lymph node dissection, ma'am, if it is not enlarged node.
Okay, you don't expect to find germ cell tumor in this case. You are right that you can avoid germ cell cancers, lymph node dissection in germ cell tumors. Which type of germ cell tumors do have a propensity of lymph node spread?
Dysgerminoma, ma'am.
Very good, yes. So even in dysgerminoma, we don't do a systematic lymphadenectomy. We actually remove lymph nodes which are involved because these patients are highly chemosensitive and almost all of them go for chemotherapy. Okay. So forget about now germ cell tumor in a 65-year-old. I don't expect to find a germ cell tumor. One is serous cancers. In high grade serous, you should do a lymph node dissection. Okay. Low grade serous is uh, controversial. Some people do, some people don't do, but the chances of finding a low grade serous in a 65-year-old is still less. What other type of histologies can you avoid a system? Okay, let me put it this way. Which histologies don't have a propensity of spreading to lymph nodes?
Ma'am, borderline. I
The
don't.
borderline and low grade, I agree. Borderline low grade, it is part of the serous spectrum. Mucinous cancers, okay? Mucinous cancers don't have a lymph node spread. So you can avoid lymphadenectomy in mucinous ovarian cancers, okay? Any mucinous cancers, the lymph node spread is 1 to 3% only. So we don't do a systematic lymph node dissection in mucinous cancers. Second is granulosa cell tumors. Again, in granulosa cell tumors, they are common in perimenopausal and sometimes even in postmenopausal age group. In granulosa cell tumors also, you can avoid a lymph node dissection. Okay. Now, in which patients can you do a fertility? Now, this case is there. You've done a staging laparotomy. That's the correct management. Are there any cases where you could do a fertility preserving staging, as in you could save the other ovary uterus? Which type of cancers can you offer fertility sparing surgery?
Ma'am, in 1A, grade 1, 2, with mm, histology of non-clear cell histology, ma'am.
Yeah, correct.
Mucinous endometrioid.
Very good. Yes. Clear cell is controversial, but you're absolutely right. Stage 1, grade 1 or 2, serous, mucinous, and endometrioid, you can offer fertility sparing surgery. Okay. Now, okay, what else? Just give me 1 second. I had a few questions. Just give me. Okay. So, when you are when you are operating, okay, are you routinely doing appendicectomy
Yes, ma'am.
in any patient? Why? What is the reason?
Ma'am, because of that mucinous neoplasm of the appendix.
Yeah, okay. So even in mucinous now there are enough meta-analysis. There are meta-analysis to show that if your this thing appendix is normal, you need not do a routine appendicectomy in mucinous ovarian cancers. In pre-operative workup, do you do endoscopies for all patients, or are there any selected patients for which you do endoscopy?
Selected patients
Where do you do endoscopies? In which
and
patients?
with when patient having GI symptoms and in bilateral ovarian tumor and with patients with atypical presentation, we will do, ma'am.
So, yeah, the correct answer, you are right. So, patients who have GI symptoms, okay, who have a decreased CA-125 or C by CE ratio, have a markedly elevated CEA or CA 19.9, okay, or they are showing something suspicious on their CT imaging, okay. So presence of bilateral, yes, you do tend to think about metastatic tumors when there are bilateral tumors, but you need to understand that about 15 to 20% of serous cancers are bilateral. In fact, more than that, 20 to 25%. That may not always be the reason for doing an endoscopy. More important is presence of GI symptoms and elevated markers.
Access.
Okay. All right. Just give me 1 second. In the meantime, even your participants can put some questions. So we are just discussing early case this time, right? Only early case. Okay. So what was the report you did? You did the surgery. Can you show the histopathology report now?
Yes, ma'am.
Yeah, please.
Ma'am, even in postmenopausal lady, we can give endometriosis as a second differential diagnosis, ma'am.
In postmenopausal active endometriosis is less common. Yes, you are right. But sometimes we do find sequelae of endometriosis. Yes, you are right. In a 65, that is why you can say because she's already 65. But we are discussing different case scenarios. So yes, had she been, we do find cases where patients who have stopped. So when a woman has cessation of menses, your ovarian function does not stop immediately. You need to understand there might be a gap where the ovaries are still functioning even after cessation of menses. In a 65-year-old, you are right, endometriosis is less likely. But in a 50-year-old also, the ovaries can function after cessation of menses for up to 5 to 10 years. Okay. So patients who've had these sequelae of endometriosis may develop. Okay, yeah. So can you just share your histopathology?
Can you see, ma'am?
If you can make it full screen, that would be great.
This is the full thing we can do.
You can come to the microscopic. I think this is too small for me to read as well. Yeah, you can just describe the microscopic. Yeah, so it's fallopian. Read it out. Yeah.
Yes, ma'am. Lesion site is fallopian tube size of 11.5 into 10 into 4 centimeter. High grade serous carcinoma, ma'am. With the POT deposit alone, it is positive. And rest all peritonectomy and omentectomy was negative. And lymph node is pelvic is 0 out of 14 and retroperitoneum is 0 out of 7. T2B, ma'am.
Okay, so FIGO staging. So in gynae, we go, of course, you should know your TNM also, but what would be the FIGO stage of this disease?
2B only, ma'am.
Yeah, okay. So POD deposit is positive. All right. So how will you manage this patient further?
Adjuvant chemotherapy with 6 cycles of paclitaxel and carboplatin.
Okay. So when do you normally start chemotherapy? After surgery? How long after surgery?
Usually after, when the patient gets recovered within 2 to 3 weeks, ma'am.
Correct. Yeah. So 3 weeks, 2 to 3 weeks, we normally start chemotherapy. How is this chemotherapy given? How much dose do you give and how frequently do you give it?
Okay. Paclitaxel is 175 mg per meter square, and carboplatin is area under the curve 5 to 6. This 3 weekly regimen.
Correct. Right. And is there any other regimen besides the 3 weekly regimen?
Dose dense is also there. It
Yeah.
is weekly regimen.
Mm-hmm.
Paclitaxel 80 mg per meter square and carboplatin area. Also, if given weekly, then it is area under the curve 2. It is given weekly.
What are the advantages or disadvantages of giving weekly over 3 weekly?
Ma'am, weekly disadvantages is toxicity is more.
Sorry, come again.
Weekly is toxicity is more.
Actually, what they say is the toxicity, it is more tolerable. So the neurological toxicity is less. Hematological toxicity is debatable. There are some studies like the Japanese trial, which showed that there was an advantage. There was even a survival advantage in the Asian population. But when they replicated it in others, including the European studies, they did not find that survival advantage. Although many times patients are now getting weekly chemotherapy as well. Okay. So, of course, this is an early case. Okay, so we are only discussing early case today. So there's much more to discuss in this thing. In a case of advanced ovarian cancer, I think we can take that up next time. So what are the differential? Okay, we'll come to the viva questions now. What are the differential diagnosis of an adnexal mass? When you talk about adnexa, so what are the differentials you can think of?
Ma'am, malignant ovarian mass, benign ovarian mass, or mini hydrosalpinx.
Okay, one is any ovarian mass that can be benign or malignant. The other is a tubal mass. Tubal mass can arise due to pelvic inflammatory disease. It can arise due to pelvic tuberculosis, or it can arise in a young woman due to
ectopic also.
Yes, very good. Ectopic pregnancy. Okay. So in a young woman, you should always be asking for her LMP. Even if she's, there's no overdue, it's always a better idea to do a UPT. Okay. What else? What are other differentials of adnexal mass?
Then we can come to, uterine
endometriosis, uterine mass.
Yeah, endometriosis is ovarian. So fine, ovarian masses, both benign and malignant. Okay, it can be anything. It can be a hemorrhagic cyst. It can a complex mass. An endometriotic cyst can present as a complex mass. Okay, then you can have your malignant masses, tubal masses. Now, uterine masses. What uterine masses can present as an adnexal mass?
Large fibroid. Large fibroid uterus.
Which type fibroid? Which type of a fibroid would be confused as an adnexal mass?
Subserosal type.
Correct. Yeah, because see, subserosa is projecting outside the uterine contour. So it can be subserosal fibroid, a broad ligament or a pseudo broad ligament fibroid can be confused as an adnexal mass. What else? What else lies here in the adnexa? What else can be confused?
Any mesenteric system.
So, I didn't get your this thing. Appendicular mass, diverticular mass. Okay. So just don't think of only gynecs, this thing. Whenever you're thinking of, masses, it can be an appendicular mass or a diverticular mass as well. Okay. Uh, okay. All right. So we have talked about role of lymph node dissection. All right. Now let's just come to familial breast and ovarian cancer syndromes. So we've talked about BRCA1, BRCA2. This is what we should do in any high-grade ovarian cancers. Nowadays, in fact, all patients of ovarian cancers are being advised germline testing. Okay. So in hereditary breast and ovarian cancers, what are the risk reducing measures which you can offer? First of all, what cancers are these patients prone to? Number one. Number two, what are the risk reducing measures you can offer to these patients?
In BRCA1 and BRCA2, both are for breast and ovarian cancer. The for BRCA1, cancer occurs much younger than BRCA2. And chances of getting ovarian cancer is 40 to 50%, and age at presentation is also 35 to 40%.
35 to 40 years, yeah.
40 years, and BRCA2 is between
Around
20%, and the age at presentation is little bit later with 40 to 45 years, and the risk reducing surgery is bilateral salpingo-oophorectomy. Risk reducing bilateral salpingo.
Tell me all the risk reducing measures. You don't need to come to surgery first. So one is breast. So these patients have an increased chances of breast cancer, ovarian cancer, of course, pancreatic cancers and prostate cancer in men as well. Okay, and in male breast cancers. Now for ovary, so there are some preventive measures. For breast, there are some preventive measures before we come to risk reducing surgery. So can you enumerate all of them?
In breast, first we active surveillance versus chemo prevention. Chemo prevention with tamoxifen, and for breast we can do risk reducing mastectomy.
First, elaborate the surveillance. That's the most important part.
Surveillance,
Because
okay.
most patients may not go for mastectomy because of body image issues. So surveillance is important. How do you do surveillance for a patient who's BRCA positive for breast?
We have to do bilateral breast MRI, ma'am.
Okay. Starting from what age?
From
Clinical breast self-breast
18,
examination
18,
from what age? Yeah.
From 18 years, ma'am.
Hmm.
Clinical breast examination with imaging, first imaging of bilateral breast MRI, ma'am.
Yeah, so it is from 20 to 29 years and then 30 years onwards. Okay, so read this up. This is there in your NCCN guidelines. This is important. It can come both as a short note and they can ask you. Okay, so it's quite, you have to do alternating mammogram and breast MRI. A contrast enhanced MRI is better. Okay, so this is for breast. The surveillance part is important. It is there in your NCCN guidelines. Please read this. Okay. Second is chemo prevention with tamoxifen. Third, you talked about the risk reducing surgery, which is bilateral mastectomy. Now, ovary. Now, tell me the risk reducing features for what you can do to reduce the chances of ovarian cancer.
Ovary, actually, screening is not it is useful with ultrasound and CA-125. It's not proven, ma'am. Only with.
Are there any trials which have shown any futility or any usefulness of screening for patients?
PLCO trial showed that is not for this.
Yeah, PLCO is a very old trial, but recently we have the UK TOX trial for the general population, and UK FOSS trial for the patients who had familial breast ovarian cancers. So they found they used something called risk of cancer algorithm, which was based on the rise of CA125 and the premenopausal and postmenopausal status of the patient. So they had an algorithm. So based on that, they basically divided patients into patients who underwent surveillance with this ROCA algorithm and an ultrasound. The other was only ROCA algorithm, and third was only nothing. Nothing was done. Okay. So they found that they were able to pick up stage 1 and stage 2 cancers more frequently as compared to no surveillance. But this did not change into any change in the survival. So although they were able to pick up the early cancers slightly more, the survival rates of the patient did not improve. Okay. So as of now, and this is something which is very important, which you need to tell patients who are carriers of pathogenic BRCA mutation or even minor mutation. Number one, for breast and ovary. For breast, you have active surveillance as an option, which is an effective option. Okay. But in ovary, unlike breast, there is no effective screening option. That is why the role of chemo prevention, but more importantly, the role of risk reducing surgery becomes very important. Okay. So, what is chemo prevention in these in these patients? What do you offer for chemo prevention for ovarian cancer? You told me
Let's
before also, you gave me a figure also, 5 years, 50% decrease.
see.
OCPs.
See.
So, yeah, so OCPs do have some slight risk of breast cancer, but we still offer OCPs for these patients because breast is screenable. Okay, as a chemo prevention, oral contraceptives are still offered to these patients. And third is risk reducing surgery. So, when should you offer risk reducing surgery? What all should you tell a patient to whom you're offering risk reducing surgery? So, if a patient comes to you, she is BRCA1 mutation positive, okay? You have to tell her about the benefits or the side effects of risk reducing surgery. So, what all should you tell the patient?
Ma'am, first, whether she has completed her family or not.
Yeah.
Um, and then we have to tell about the negative side of like
What is the
post-menopausal
positive side? Let's
symptoms.
talk about the positive side,
Positive
please.
side is there is chance of risk reducing in ovarian cancer up to 85 to 95%.
Correct. Very
That's
good.
an
Yes.
advantage.
So that you talk about the advantage first. First, you ask her whether she has completed her family. Then you tell her that according to her mutation, whichever mutation she has, she is more likely to develop these cancers, say ovarian cancer at this particular age. If she's a BRCA1 mutation positive, normally we offer RRSO at 30 to 35 years of age. And because BRCA2 mutation occurs later, we offer RRSO at slightly later age, 40 to 45 years is good enough. And you have to tell her that yes, this will reduce your chances of ovarian cancer by 85 to 90%. But, but,
Still, they can have primary peritoneal malignancy.
correct, very good, very good. In fact, we've had patients who've undergone THBSO and they have presented with primary peritoneal. So you have to tell them that there will be a definite risk reduction of 90% of ovarian cancers, but there is a still 4% chance that they may develop primary peritoneal cancer. Is there any link of doing RRSO to any reduction in breast cancer risk?
Yes, ma'am. Breast
Yes,
also it is up to 50 to 60%.
Up to 50%, although there are controversial studies nowadays, but yes, older studies do have a risk reduction of up to 50% in breast cancer. And the disadvantage, of course, is that she will have early menopause. Okay. Now, when you're doing risk reducing salpingo-oophorectomy, uh, what precaution should you take? Not precaution, but what should you actually ensure when you're doing an RRSO?
If we do in the laparoscopy, then we have to take the specimen in the bag, ma'am. We should not contaminate.
Correct.
Yes.
That is one
we
thing.
And
remove the fallopian
the
tube
tube
also.
also completely.
Correct. So what is very important is we have to remove the fallopian tube completely right up to its cornwall end, avoid any spillage or any disintegration of the tissue. Take it in an endo bag. Very importantly, take at least 2 centimeter of the infundibulopelvic ligament. Okay, so many benign surgeons, what they do is they just cut the ovary at the ovarian ligament, cut the fallopian tube, just detach it from the uterus, and they call it RRS. So that is not RRS. So when you're doing a risk-reducing salpingo-oophorectomy, we have to open the peritoneum, visualize the ureter, and take at least 2 centimeter of infundibulopelvic ligament. Okay, and then after you have retrieved it in the endo bag, if you have the facility for it, what should you do on this specimen? What is that thing called? See your chat box. I'm pretty sure there must be prompts there. CFIM. What is CFIM?
Don't know, ma'am.
Don't know, ma'am.
CFIM is a protocol. So when you, so we know that your ovarian cancers, your fallopian tube cancers, and your primary peritoneal cancers, basically the origin is distal end of the fallopian tube. Okay. So what the pathologist does is this part of the fallopian tube, he or she extensively sections and examines it. So sectioning extensively and examining the femoral end, that is called CFIM. So they take extensive sections to see if there is any pre-invasive or invasive disease found in these tubes. Okay, so there is a high chance of you know, finding something like STIC, which is serous tubal intraepithelial carcinoma, and there is a 2 to 9% chance of finding an early disease in this specimen, provided they do the CFIM protocol. Okay, so always for these patients, take 2 centimeter of infundibulopelvic ligament, take the fallopian tube in entirety up to the uterus, avoid any morcellation of the tissue, retrieve it in an endo bag. Always take peritoneal cytology. Even when you're doing an RRSO, please take peritoneal cytology. Reason being that 2 to 9% of the patients you may find STIC or early cancer. So peritoneal cytology is always good. Now there is controversy if you find early cancer, should you go ahead and stage it? We'll not fall into this controversy. That's not an exam question, but okay. So you should do this. Should you also do a hysterectomy for these patients? Patients who are BRCA or any minor gene positive who are predisposed to these hereditary breast and ovarian cancers. Should you also offer them hysterectomy?
Lynch syndrome.
Ma'am, Lynch
Yeah,
syndrome.
Lynch syndrome, definitely. I'm talking about HBOC, hereditary breast and ovarian, BRCA related. So there is a school of thought that these patients are at slightly increased risk of uterine papillary serous cancers, but this risk is very minimal. It is about 1 to 2%. So as of now, routinely, we are not doing hysterectomy along with salpingo-oophorectomy. But there is one advantage of doing a hysterectomy. Uh, I will come to that advantage later. So suppose you've done an RRSO, patient develops premature menopause, starts experiencing menopausal symptoms, hot flashes. Can you offer this lady HRT?
Decreased estrogen content.
No. First answer whether yes or no. There are only two choices. You so yes or no first. And what are your thoughts behind it? Can you offer these patients HRT? Because they are developing premature menopause. Okay, they may experience very excruciating hot flashes or symptoms. Normally, we offer HRT, but in these patients, because they are in any case predisposed to breast cancers, can you offer them HRT or not? Okay, so I'll tell you the answer. The answer is yes. You can offer them HRT up to the natural age of menopause, but HRT should be given in the lowest dose possible for the lowest time. Okay, so ideally it should be the lowest dose till the lowest time, but it can be offered up to the natural age of menopause, provided, of course, that you are doing your breast surveillance. Okay, so it can be offered in any form. It can be offered as a local therapy. It can be offered as a low dose oral therapy also, provided, of course, that you are doing a breast surveillance. Okay, now, so the advantage, if any advantage there was of doing a hysterectomy in these kind of patients is, say, So for this patient, if you were to offer HRT, okay, if a patient who for whom you're doing an RRSO, you wanted to give HRT. Now, if the uterus is in C2, you'll have to give both estrogen and progesterone. You cannot simply just give estrogen and HRT because that will lead to increased endometrial thickness that can
Hyperplasia.
increase the chances of this thing. Okay.
Movements.
So you have to give progestins, and progestins are counterproductive for breast CA if the patient has it. Okay. So the only advantage of doing a hysterectomy in patients is you do hysterectomy for these patients if they have any symptomatic uterine pathology, like let us say they have symptomatic uterine fibroids, then you can remove the uterus along with tubes and ovaries. Okay. Second is if in case you are considering HRT, then in those cases, if you remove the uterus, you can offer only estrogen, which is better than giving estrogen plus progesterone in terms of the breast part of it. Okay. So that's the only advantage of doing a hysterectomy. Otherwise, normally we don't do a hysterectomy. Okay. Now, have you heard of HE4 as a tumor marker?
Yes, ma'am.
Okay. So where can we use HE4?
Ma'am, HE4 in case of diagnosis dilemma, we can use, ma'am, because it is
Okay.
more sensitive, more specific, ma'am, more specific.
It is actually both more sensitive and specific. So HE4, so where is the dilemma? In which cases is there a dilemma? What does it help in distinguishing between?
Ma'am, when CA 125 is not much elevated,
Hmm.
then to difference between malignant and benign.
Okay, first, one thing which I want everyone to take home is practically there is no cutoff. Okay, there is no cutoff of CA 125 at which I can say, no, this is an endometriosis or no, this is a cancer. We have seen cases of endometriomas having raised CA 125 up to 2000, 4000 also. So that should not be a criteria of defining whether this is an endometrioma or it's a malignant mass. Okay, that is one thing. You have to go by imaging. Okay, so HE4 is useful in cases of complex adnexal masses in young women where the common differential is endometriomas or endometriosis. So CA125 is raised in endometriosis as well as in ovarian cancers. On the other hand, HE4 is normal in endometriosis or endometriomas, whereas it is raised in C ovary. Okay. So whenever we find a complex mass, especially in a young woman, we use HE4 along with CA125 along with the contrast MRI. Okay. So basically what you whether the mass is benign or malignant has to be on the based on the combination of these factors, not just one. Okay, not just no HE4 is normal, so it is this thing. No. Imaging, what is your MRI saying? CA125 may be raised in both, but if HE4 is normal, that is tilting more towards endometrioma or endometriosis because HE4 tends to stay normal in endometriosis and endometrioma. So it is a more specific marker. Okay. Here it is more specific because CA125 was raised in both, but HE4 was raised only in ovarian cancers, but normal in endometrioma or endometriosis. So here it is more specific. Where is it more sensitive?
Recurrent cases.
Yes, very good. Nowadays, even in early cases, they are finding that sometimes if CA125 is normal. So, anytime, you see a gynecologist calling you and saying, oh, CA125 is normal, I think this is a benign case. We can just take it out by laparoscopy. Always go for the imaging because CA125 can be normal in up to 50% cases. Okay. Now, HE4 is an expensive investigation. It may not be available everywhere. So you should always advise an MRI or in those cases and go by the imaging. Okay, so this is where HE4 is more sensitive. Okay, so now fine. So this patient, you have given 6 cycles of chemotherapy. How will you follow up this patient?
Ma'am, 3 monthly follow-up for first 2 years and then 6 monthly for till 5 years with the clinical examination and then ultrasound of the abdomen
Anything else?
and tumor marker. Ma'am.
Correct, right. So clinical examination, imaging as and when appropriate. Okay, sometimes if the patient has clinical symptoms, you may like to go for CT straight away rather than an ultrasound, but imaging according to what the clinical symptoms are and what the patient is saying. So yes, it can be an ultrasound if it is a regular follow-up. In case patient has some complaints, then we may like to go for a higher investigation as well, along with CA-125. Okay. Now, let us say this patient, after 1 year, mm, after 1 year, she starts having a rise in CA-125. The CA-125 is rising to 66. Then subsequently, after 2 weeks, you do it has risen to 75. What will you do for this patient?
If the patient is asymptomatic, then we can repeat it. There is no active intervention for asymptomatic.
Asymptomatic, and there is no radiological evidence of disease. If it is only a biochemical recurrence, then we can observe the.
Is there any evidence? Is there any level 1 evidence or any evidence for that matter to support that you can just keep these patients on close surveillance?
O5.
Yes, OV5 trial, correct. So what was the OV5 trial? Basically, patients who had only biochemical relapse. By that, it means only a rising CA-125 with nothing much on radiology and asymptomatic. So they divided these patients into two groups. One group received immediate chemotherapy. The other group was followed up till they became symptomatic or there was a radiological progression, and then they gave them chemotherapy. So they found that there was no difference in the survival rate between these two groups. Okay, patients who received late chemotherapy had the same survival rate as those who received immediate chemotherapy. And the quality of life, on the other hand, was better in patients who received delayed chemotherapy. So this is your basis for keeping these patients on close surveillance. Okay, many times when patients have biochemical relapse, some medical oncologists would like to keep them on hormonal therapy like tamoxifen or letrozole as well. Okay, so let us say at 14th month, there is patient starts experiencing some heaviness in the abdomen. So what else would you advise besides CA-125? Would you like to do any imaging?
Yes, ma'am. If symptomatic, then
What
CCT.
would you do? Yeah, you can do a CCT. You can even do, if you're considering, because she's had a long disease-free interval, if you're considering this thing, if you're considering, just give me 1 second, I'm really sorry. So if you're considering, if this is because the recurrence is after more than a year, if you're considering that, if you're considering whether this patient might be up for something, you may even offer a PET CT. Okay. So you do a CT scan. Okay. You find some disease, some thickening in the paracolic region. Okay. Minimal ascites. And that's it. No pelvic nodes, upper abdomen is normal. So what will you do for this patient? There is peritoneal disease on the paracolic gutters. Okay. And what else did I say?
Minimal ascites.
Minimal ascites, correct. Minimal ascites. Some query deposit on the surface of the liver. That's it. The general condition is good. So what will you do for this patient?
DFI is 1 year, if you said, no?
14 months, correct.
Then we can offer surgery, ma'am, secondary cytoreductive surgery, ma'am.
Okay. So what is the evidence? What evidence can you tell me about some evidence which we have for secondary cytoreduction?
Desktop 1, 2, 3, ma'am. First, whether it.
What is the ego criteria?
It is a good performance status with ascites less than 500 ml, with DFI of more than 12 months, with platinum sensitivity, and primary cytoreduction was CCC.
Yeah, it was done. Okay, all right. Yeah, it was done by an oncologist and it was optimal. The condition is good. Okay, less than 500 ml of ascites. Okay. So desktop 1 and 2. Desktop 2 was basically a validation of desktop 1, and then came desktop 3. Okay. Besides desktop 3, there are two more important trials for secondary cytoreduction.
GOG 2 and 3, which was a negative trial. Um, and shock one நினைக்கிறேன்.
Fuji trial.
Shock
It was
one.
a Chinese trial. It was called SOC1. Okay,
Shock
that
SO.
also, so that also showed benefit for secondary cytoreduction. So, desktop 3 did show fine benefit for secondary cytoreduction.
Progression.
Followed the specific ego criteria. The SOC also I followed the I model criteria for secondary cytoreduction. You can read that up. So that also found good survival benefit with secondary cytoreduction. On the other hand, GOG 213 did not find any benefit with secondary cytoreduction. What was the reason why there was no benefit in GOG 213, but there was benefit in desktop 3 and
Because they did not follow, they followed stringent criteria in desktop. But
Okay, what else? More important than that? One is this that yes,
Bevacizumab was given which mitigated the.
right. So bevacizumab was given in more than 85% of the cases, which may have mitigated the benefit of secondary cytoreduction. And yes, there was no fixed criteria in GOG 213. The secondary cytoreduction was based on the physician's discretion. Okay, so that was the difference. So you talked of platinum sensitive relapse. Now, can you tell me what is platinum sensitive disease, what is platinum resistant disease, and platinum refractory disease?
platinum sensitive is when the relapse after 6 months. Resistance is less than 6 months, and refractory is when the patient is on treatment.
Yeah, sorry. Can you do the? I'm sorry. Yeah, platinum sensitive is
More than 6 months, ma'am. Relapse
correct.
after more than 6 months.
Yes,
Resistance is less than 6 months, and
correct.
refractory is when the patient is on the treatment. If disease is increasing, then
Yeah. So disease progression on chemotherapy makes it platinum refractory. Less than 6 months is platinum resistant. More than 6 months is platinum sensitive, but 6 to 12 months is partial platinum sensitive. So, normally, even though the disease, let us say the same, okay, now let me ask this question to you. Let us say that disease occurred, this recurrence, instead of 14 months, it happened at 8 months. Would you still offer her secondary cytoreduction?
ma'am,
It's
but,
a tricky question.
but
It's a
according to
tricky
that,
question, but yeah, tell me.
EFI of 12 months, ma'am.
Yeah,
According to
so ideally, yes, we should ideally have, even if it is optimally, if you feel it is operable, even then the tumor biology per se should be good. So if your disease-free interval is a reflection of the tumor biology. If the tumor biology is poor, the disease will recur early. So even if you go ahead, remove everything, then also there is a chance of the disease coming back again because of its aggressive pathology. That is why we keep 1 year. Okay, when we talked about desktop 1 initially, they said ideally it is 2 years, but at least it should be 1 year. Okay, so yes, at 8 months you would not like to offer her secondary cytoreduction. Okay, now in this lady, in at 14 months you would want to do a secondary cytoreduction. Okay, so you go ahead, remove the disease. Would you offer, although I know we are discussing early case now, but because we are discussing secondary cytoreduction, would you offer HIPEC in this case?
um, hyper interval.
We'll discuss HIPEC later when we are coming to advanced, but still, because we are for the sake of completion, because it's a secondary side. Do you offer HIPEC in these patients?
No, ma'am.
No.
Yeah, right now, till now, we don't have an evidence, although there are trials which are coming. Okay, but as of now, in the universal in whatever guidelines we have currently, the European guidelines and the NCCN guidelines, if we go by those guidelines, as of now, HIPEC, the evidence we have is only for the interval setting. As of now, it is not there for primary and secondary setting, although now we have results of newer trials as well, but they have not come into the guidelines. Okay, so fine. Uh, is there any place where you can give radiation in a case of C ovary? Now we're talking of recurrent disease. Okay. Now we have talked about primary disease because this is early case. You followed it up with chemotherapy. Then the patient was on follow up. She had a recurrence. You did a secondary cytoreduction. Okay. Now, is there any role of radiation in a case of C ovary? Normally,
Ma'am,
we give chemo. We don't talk of radiation at all.
I mean, dysgerminoma we can give, but not.
Yes, dysgerminoma, it was given previously when the chemotherapy. Now we have effective chemotherapy, BEP. Okay, before we had BEP, or nowadays actually people are just giving EP also. So before that, yes, radiation. It was a very radiosensitive tumor, so they would give radiation. But nowadays, no. What are some conditions where you can offer patient radiation in a case of C ovary? Okay, the hint is that
Liver,
in recurrence, can you offer radiation to some patient in a recurrent ovary?
mets or bone mets,
But bone mets are very rare in ovarian cancer. Again,
liver
I'm
mets,
saying the same thing.
parenchymal mets, parenchymal liver mets.
Yeah, okay, fine. Where you can, I mean, if the patient is not amenable to secondary cytoreduction or has residual disease left after chemotherapy or is failed multiple lines of chemotherapy and it's an isolated liver disease, you can offer that disease. You can offer radiation there. You can offer RFA also. But like retroperitoneal recurrence, okay, retroperitoneal recurrence, you can offer IMRT in especially endometrioid pathology. Endometrioid pathology basically tends to have pelvic recurrence. Okay, so in pelvic recurrence, especially in cases of endometrioid, recurrent endometrioid cases with pelvic recurrence, where the patients have undergone multiple lines of chemotherapy, radiotherapy is an armamentarium which can be offered. Of course, initially we go for chemotherapy, we go for targeted agents, but if patients has failed multiple lines and there is an isolated disease in the pelvis, especially in cases of endometrioid pathology, you can offer radiation. Isolated retroperitoneal lymph node recurrence, you can offer radiation. Okay. So today is early case only. I think the rest we'll have to sort of discuss in advance because there is more in advanced than in early. Let me just see in case I'm missing something. In the meantime, I think if one of you can take questions from the chat box for the question and answer. Any questions in the chat box, if you can tell me? Because today is only early, so we are not discussing a lot about NACT and all that. We'll discuss that when you have an advanced case.
Ma'am, the role of staging laparoscopy.
Okay, that's a good question. Staging laparoscopy, the role is more in advanced, but okay, now coming to this, I'll use your question to ask another question first. Is there any role of minimally invasive surgery in ovarian cancer?
Yes,
In
in
early ovarian
stage 1A.
malignancy, when it is a small mass, then we can
Stage
offer
1A.
stage 1A, we
Am I
can
correct?
offer.
Yes, in an early case where the mass is small and it is not like say adherent to the adjacent structures, it's a free mass, not stage 2. Early cases where the disease is small, the mass is small, and you can retrieve it safely in an endobag either through the vagina or through a small this thing. You can offer these patients minimally invasive surgery in staging. Okay, now staging laparoscopy. Staging laparoscopy is basically the role of staging laparoscopy is more in advanced cancers where we are a little doubtful whether the disease is upfront operable or it is not. Okay, sometimes the patients come, they have a good clinical condition, you are considering them for primary cytoreduction, but the patient has indeterminate findings on CT. Okay, and you want to see whether the disease is upfront resectable or not. So in those cases, you can start with a staging laparoscopy. In case it is operable, you go ahead with the primary cytoreduction in the same sitting. In case it is not operable, then you take a biopsy and send the patient for neoadjuvant chemotherapy. So staging laparoscopy is more for advanced cases in indeterminate findings. We don't do it for all patients. But yes, laparoscopy or minimally invasive surgery, including robotic, including lab, can be used for early ovarian cancers. Okay. So fertility sparing, where all besides, you said stage 1A, a grade 1, grade 2, endometrioid, serous, and mucinous. Okay. Any other besides epithelial ovarian cancers, where all can you offer fertility sparing surgery?
Germ cell tumor of ovary
Yes.
and in granulosa cell.
Correct. Yes. In early, you do find granulosa cell tumors. There are two distinct age groups of granulosa cell tumor. One is a younger age group, the other is a perimenopausal age group. So definitely you can offer them fertility sparing surgery. Borderline cancers, low grade ovarian serous, you can. Now, in case of low grade ovarian, so like I told you, serous cancers have a propensity of bilateral involvement. They can be bilateral in up to 20, even 25% cases, both high grade as well as low grade. So many times so patients who have low grade cancers generally present a decade earlier as compared to those who have high grade cancers, or patients who have borderline cancers generally present in their 40s and 50s, but we do have young girls who have not completed their family coming up with borderline cancers. Okay, so if there is a young girl who presents with borderline cancer, so there is a left adnexal mass, the frozen section basically shows it's a low grade ovarian cancer. Okay, so there is a left ovarian mass around 7 into 8 centimeters. The right ovary is normal. Okay, so in these cases, what would you do? Would you just remove the mass and try to save as much ovary as possible on the left side, or would you like to remove the whole mass on the left side? Say it's a young girl who's 30 and is not married. She says, "Doctor, I want to preserve my ovaries. I want to have my own kid." So what can you tell her? So if you
If
remove the whole mass, if you do a complete salpingo-oophorectomy, the chances of recurrence there are less than 5%. Okay. On the other hand, if you only do a cystectomy or only remove the mass and preserve the ovary on that side, the chances of recurrence on that side is 25%. So if a patient is telling you, okay, no, I want to preserve this, so you can tell them, look, it is ultimately the patient's decision, but the chances of recurrence are more if you just do a cystectomy. Okay. But many times it does happen that, patients about 20% can present with bilateral involvement. Okay. So bilateral involvement may, she has a low grade ovarian mass, a low grade serous on left, low grade serous on right. Okay. So what can you do in these patients? Say you get a patient, she's 32 years old, she's unmarried, she's presenting with bilateral adnexal masses. You get an MRI showing papillary projections, ORADS 5, CA125 is 100, okay, and you are planning for surgery. What all will you tell her before surgery, and what all should you do before taking her up for surgery?
Oocyte preservation we can.
Yes, very good. So oocyte preservation is very important. You have to give all patients, all young patients, this counseling. Whether they go for it or not, whether they can afford it or not is a different thing. But you should always refer them to a reproductive endocrinologist, because nowadays they have short induction protocols wherein they can retrieve the ova within 2 to 3 weeks. And you don't really expect a lot to happen in 2 3 weeks in a low grade cancer. Okay, so you should always give them that option, because many times when you go in with the surgery, you may not find any normal ovarian tissue you can actually save. Okay. So in this patient, you would definitely give her the option of oocyte preservation. You would take the consent for complete surgery in case you don't find any normal tissue to save. Okay. In case, so in for frozen section, so for any frozen section has an accuracy of only 80%. Okay, so you have to inform the patient that the accuracy of frozen section is 80 to 85%. In 15 to 20% cases, we may find invasive cancer on the final histopathology. Okay, so you have to tell them this, that we will be doing a frozen section, but the accuracy is 85%. So we may find invasive cancer later on. Okay, so even if it is an early low-grade ovarian cancers, but it has not spread anywhere else, okay, and the patient insists on fertility sparing, okay, you remove the dominant mass, the bigger mass, okay. The other side, if there is any ovarian tissue left, you try to preserve that, but you tell the patient, I will try to preserve the ovary on this side where it is less involved, but you will have a 25% chance of recurrence, okay. So you have to inform all this to the patient. And then you also have to inform them that once they have completed their family, they have to go for completion surgery. Okay. In case you see that both ovaries are involved, there is no normal ovarian tissue left. Okay. What can you do? What else can you do in terms of fertility preserving? Is there something you can do? Say you have preserved the oocytes. Okay. You are going in for the surgery. You find left side, right side, there is no ovarian mass left. Okay. Can you do something?
From ovarian tissue, if something normal is there, we can
Yeah,
preserve
let
ovarian.
us say there is nothing left. Okay, or she has recurred multiple times. Let us assume she's had previous cystectomies or previous partial removals, and this is her third or the fourth recurrence. And you cannot save the ovaries now. She says, Doctor, I've had it. It's coming here, it's coming there. I've preserved my oocyte. Can you do something besides this? You can preserve the uterus. Okay, so if the uterus is grossly normal, you can still go ahead do a bilateral adnexectomy. If the oocyte is preserved, then the patient can have carry her own biological child, okay, with hormonal support. So you can preserve the uterus in these cases. That is also a form of fertility preserving. You are giving the option to a patient that she can carry her own pregnancy instead of using a surrogate mother. Okay, so I think that is it for early. As far as I can think, I don't know if there is any question. Is there any other question left in your chat box? Can you please see, one of you? Because there's more in advanced.
Importance of CA19-9 has been asked now.
Yeah, importance of CA19. So, like I told before, not all institutes are doing CA19.9. CA19.9 is basically to rule out any pancreatobiliary origin. Okay. But CA19.9 can be raised in a few cases of ovarian malignancies also. So, ovarian malignancies can have a raised in.
Mucinous type.
Yes. What else? Which else?
Only we know mucins.
Okay, endometrioid. Okay, even endometriosis can have raised CA19.9. We have seen CA19.9 raised up to 2000 also, even in plain endometriomas. Okay, endometriomas can have raised CA19.9. So it doesn't mean ki every time you have to go for an endoscopy. Okay, CA19.9 is known to increase in endometriosis, endometriomas, even endometrioid cancers, mucinous cancers. Some other benign ovarian lesion where CA19.9 is raised. You can think of. I cannot give you a digital chocolate, but I'll give you a chocolate in case. I'll post you a chocolate in case you tell me.
Don't know.
Teratomas.
What no?
Teratomas can sometimes have raised CA19.9. Okay. Benign teratomas can have raised CA19.9. Okay, so but that's not the so we do CA19.9 because some cancers do have raised CA19.9, but also to rule out pancreatobiliary origin. It is not imperative for you to always do CA19.9 as per guidelines. What is it required is CA125 and CA. But there are many institutes in our country which are routinely doing CA19.9 because we were routinely doing it at Tata. This is what we have been following in our clinical practice now. So most important is CA125 and CA, but CA19.9 is optional. Now, normally you say, as you can tell your institute's policy whenever you are giving an exam, just say as an institutional policy we are doing.
Yes, ma'am.
Okay.
PCOS and infertility has been asked.
Sorry, PCOS and infertility. Role of, okay. So PCOS has not been found to per se increase the chances of ovarian cancers. It has been long-standing PCOS is associated with high risk with the endometrial CS. Okay, so and PCOS can lead because it has anovulatory cycles. In anovulatory cycles, if the ovulation doesn't take place, the progestin is less and the estrogens are more. Okay, so in these cases, that causes endometrial hyperplasia. So if it is not treated, it can cause C endometrium. But in these young women who have these C endometrium, they may also have an adnexal mass. Up to 20 to 25% of these young women can have synchronous tumors, both in the uterus and a low-grade endometrioid carcinoma in the ovary. Okay, so when we were talking, even endometriosis, when we were talking about what are the cancers associated with endometriosis, long-standing untreated endometriosis is sometimes associated with low-grade, synchronous low-grade endometrioid cancers of the ovary as well as the uterus, the synchronous ones. Okay, not isolated endometrium, but the synchronous ones. Okay, So that is it. So PCOS is that. Infertility. Basically the milieu, the hormonal milieu of patients who have infertility has been shown to be associated with increased risk of ovarian cancers. The treatment which is given for infertility, which means that all the ovulating agents per se, all the meta-analysis till we have now have shown that they per se don't increase the chances of ovarian cancer. Infertility by itself is the risk factor for increased ovarian cancer rather than the ovulation induction which we give.
Okay.
Okay.
That's it. I'm just trying to see in case I have missed something. In case I've missed a question, please somebody can ask.
Ma'am, in imaging, how should you say it in exam, like use of USG or directly CT?
No, you should, yeah, ideally see. Many time patient comes with an ultrasound. Okay, so you say you always, if a patient has come without any investigation, in this case, if it's a 65-year-old with a clinically 10 centimeter mass, you can palpate a pouch of Douglas deposit. You can say, I will directly go for the investigation of choice, which is a CT. Okay, in case a patient has come with something which you need to diagnose, like you don't know where the mass is arising from, there you can start with an ultrasound. Okay, in this case, in this particular case, you can say the patient came to me, she is 65-year-old, based on my clinical history and examination, I suspect an ovarian mass which could possibly be malignant, and because it's a big mass, we in any case need to evaluate it, and the investigation of choice would be a CT. You can directly go ahead with CT in this case. But it varies from case to case. You may sometimes most of the times patients will come to you with an ultrasound. Okay. So in the exam, many times you will say patient came with an ultrasound, and you may not be given the ultrasound report, but you can always ask the patient, ultrasound, what had they told you in the ultrasound? So they may say that they said there's some mass there or some fluid there. Okay. So you can always write that in the history. Patient came with an ultrasound, which was suggestive of this. Okay. Yeah. And what is RMI? These are very bad questions.
Risk of malignancy index.
Yeah. So what is it?
It contains menopausal status, CA125, and ultrasound features.
Correct. CA125 in its natural value, plus an ultrasound score, plus pre or postmenopausal. So what is generally considered the cutoff?
25 to 100, more than 100 high risk.
200, more than 200. More than 200, it is. So basically, RMI is basically more useful for gynecologists for referring the patient to the oncologist. So if the RMI is coming more than 200, according to the ACOG, the American College of Obs and Gynae, that is basically the level at which they should refer to the oncologist. Most of us don't use these scores in our practice. Okay, we generally go by the imaging, we go by the tumor marker profile, and that is how we decide the management. These markers may not be very important for your management. They are basically important. RMI is more important for referral to an oncologist. Okay, where you have to take all precautions, because otherwise, many times what happens is patient, like I said, they say CA125 is normal and this is this thing, and you do a laparoscopy. So obviously there are chances of disease spill and spread everywhere and upstaging of the disease. Yeah, I think so. That is it in early case. Adjuvant chemo. I think that's it. It's early May. If you missed something, all the questions are there. Yeah, we don't. So screening is, see, that's what these are all newer markers, HE1, OVA1, mesothelin, all these are coming up, even ROCA, risk of cancer algorithm. As of now, none of the screening protocols have found any benefit in screening. So even the most important trial, that is the UK TOX and UK FOSS. These are UK trials, okay? UK TOCSS and UK FOX, but that was for familial cancers. So they found that even using these ROCA algorithms, using ultrasound, although they were able to pick up stage 1 and 2 early, it did not reflect in change in the survival rate. So as of now, we are not doing screening. I mean, screening for ovarian cancer has not been found to be any useful. See, all are have their own advantages. All are sensitive. HE4 is more sensitive. So, in case, for instance, I could argue that if I have the facility for HE4, imaging is looking suspicious. Somebody is insisting on, morcellating the disease, saying CA125 is normal. I could argue that I would like to do HE4. In clinical practice, what we are doing is basically CA125. HE4 we are doing. HE4 we are doing for a lot of young patients, okay, because I'm working in a private setup where patients can afford it, okay, but it may not be applicable everywhere. Okay, as of now, no, nothing for screening as of now. These are different markers, each has its own profile, each has been found to be useful. So all these ORAD scores, simple rules, these are basically to distinguish benign versus malignant. Okay, so these are ultrasound scores or even MRI scores which have been developed to say whether the mass is likely to be benign, complex, or malignant. Okay, so this when you do an MRI, normally the radiologist gives you this thing. They give you these are suspicious findings, and any good reported report they will always mention ORADs, like they mention BIRADs. Nowadays, many radiologists have routinely started describing ORADs as well.
Ma'am, thank you for the class, ma'am. My question is on follow-up with CA125. Now it is raising above the nadir. Do we serially assess for the raise in subsequent second or third value?
Yes, ideally you should, although in practice people don't do it, but yes, ideally you should. But the baseline still remains. If the patient is asymptomatic, you just follow them up till symptoms appear or there is radiological progression, and that is when you start chemotherapy.
And no, for the imaging, ma'am, when do the first raise above the nadir, you do an imaging, confirm that there
It
is no
is better.
structure.
Yeah. It is better to do an imaging because that is, if the patient can afford it, yes, we at the CA125 rise, we do an imaging, but you need to realize that any imaging, whether you do a CT, whether you do a PET CT, okay, they have a sensitivity of about 8 millimeters. Okay. So any disease which is less than 5 to 8 millimeter in size will not be picked up in any imaging. So it is quite possible that at a CA125 of 73, you may not find anything. There might be some disease in the abdomen, but it does not get picked up by imaging because it is too small. Okay. So, yes, ideally, you should, when you find a rise of CA125, you should have a baseline imaging so that because you are keeping the patient on close surveillance, you are not starting chemotherapy. So, the only way you can be assess radiological progression when you keep the patient on clinical surveillance is most of the times what we do is we do a baseline CT, okay, when the CA125 is rising. We normally ask them to follow up after 6 to 8 weeks. Again, we do a CA125 and if possible, an imaging. If the patient becomes symptomatic. Ideal is you should wait till the patient becomes symptomatic to actually start doing all the do the again repeat radiological imaging and the chemotherapy. But in practice, many times we see that medical oncologists start chemotherapy early.
Okay, thank you.
Yeah.
Thank you, ma'am.
Yeah, okay. Thank you.
Thank you, sir.
So you should definitely have a class. I mean,
Yes.
whoever you keep it with, but please have a class on advanced ovarian cancers because that's a very big topic.
You have conference till when, ma'am?
I have conference on Thursday, Friday, Saturday.
Next week I'll message.
Yeah, next week we can keep. So advanced cancers may be a long class because there are many trials and
Yes,
everything.
please.
So you may want to divide it into two parts. Otherwise, people won't retain.
Okay, ma'am.
Okay, ma'am.
And okay, you've not recorded this. Otherwise, it would have been a good idea to record it
But
and pass
I have recorded, ma'am.
Oh, great. Awesome. Please, because all these classes are useful for others also. There might be others who may have missed it,
Yes.
and we can always share it amongst our groups.
Yes.
And if possible, can you kindly share me the recording link if
Yes.
possible?
Okay, ma'am.
Okay. So
Okay.
yeah, we'll keep an advanced class. In fact, I feel we should keep two classes for advanced ovarian cancer.